as we have already known, the stomach cancers have the dismal survivals, with 5-year survival being alone around 25%. And if you see the esophagus, 5-year survival or overall stage is only up to 12%. With majority of the inputs given by my colleague Dr. Bharat, NACT has definitely improved the game with respect to the survivals. Let us now see, did the adjuvant made any difference, and if so, what all the conditions where you wanted to add and what therapies you wanted to add in the adjuvant setting. If you see the 5-year survival rates for the gastric cancers across the region, poor prognosis in the Western countries, like 5-year OS is approximately 25%. And if you see the Asian countries like Korea and Japan, the 5-year OS is more than 60%. The majority of the times, because more so with the screening and we are able to diagnose the tumors in the early stage. And second thing, the treatment pattern including the multidisciplinary in these Eastern Asian countries, especially Japan. If you see the regional difference in the treatment of operable gastric cancer, like for example, if you see the North America, usually they follow like post-op CCRT, and if you see the European side, they usually go ahead with perioperative chemotherapy, especially previously ECF, now with more so with the FLOT, and now we know FLOT is most commonly used. And if you see the Asian, that is Korean or Japan data, usually we go ahead with the post-operative chemotherapy, might be a CAPOX or S1. So if you see the randomized trial till date, oncologists have grouped these tumors like either it could be pre-perioperative chemotherapy, or it could be post-operative chemoradiation, or it could be post-operative, that is adjuvant chemotherapy. The third part I'll try to concentrate. Localize, this will have already been covered. If you see the evaluation of neoadjuvant and the adjuvant, like previously only surgery in 2000, then came perioperative, like for example in 2006, 2007 we have got MAGIC trial which has improved the survivals. From there the French trial in 2011 and 2012. Then now in 2019 FLOT has become the standard of care. Anything above what we are trying to do now is anything above the FLOT results have been possible? Yes, no? Yes, we have trials coming up, though the OS has not been matured yet. We have got FLOT plus Durva data also coming in. If you see the ACTS GC versus classic trial, mainly the two adjuvant trials which we usually follow, one in Japan, the second one in Korea. Like if you have got resected stage 2 to stage 3 gastric resection, post D2 resection, if you have randomized to surgery alone, versus S1 for duration of 1 year, versus the Korean trial, that is gastric tumor stage 2 to stage 3 after D2 resection, operation alone, versus CAPOX of 6 months. There is a clear-cut difference in the 5-year overall survival from 61 to 71, whereas in the classic it is 69 to 78. If you see the DFS also, there is a 10% DFS improvement, that is 5-year DFS from 53 to 63. So if you see the subgroup analysis, by adding the adjuvant treatment, which stage has got a maximum benefit, coming to the ACTS data and the classic data, if you go ahead with S1 alone, surgery alone, it is 61% for all comers, whereas 71 with S1, whereas in stage 2, that is 71 versus 84, 57 versus 67, and 44 versus 50. Approximately, if you see, almost to a tune of around 10% benefit by adding an adjuvant therapy along with the surgery alone. Same is the case with the classic. 69 to 78, 79 to 88, 63 to 70, 45 to 66. More or less, majority of these hazard ratios being 0.6 to 0.7, approximately around 30 to 40% of the percentage benefit, and numerically it is around 10 months.